Okay, great. So thank you everybody for joining us for this month's Miami Global Brain Tumor Symposium. I'm gonna have some help today with the slides, Alexis. So very excited for today's guests, and we're gonna get to the introduction in a second. But first, just get to the background of our symposium. Next. So my name is Michael Ivan. I'm one of the neurosurgeons here at the University of Miami, one of the brain tumor and skull-based specialists, and I'm joined today by my colleagues, Dr. Komatar, who is our program director and also director of neuro-oncology, as well as Dr. Morkos, who's a professor and co-chairman, director of our skull-based program, and Dr. Carolina Benjamin, who's director of our skull-based lab and assistant professor here at the department. Next. We continue to put on these monthly symposiums, bringing you really novel information about brain tumors, and I couldn't do it without the support of our administrators from Sylvester Comprehensive Cancer Center, the University of Miami, and the Department of Neurosurgery. And I thank them all for every month really getting everything together for us to make this possible. Next. If you want to learn more about our symposiums or learn about or listen to our past ones, you can always find information on social media. They're all recorded on YouTube. We have over now, I think, somewhere around 10,000 views on our symposiums over the last year and a half. So please encourage you to follow them. Also follow us on social media so that we continue to grow and share all of this valuable information. Next. Next. So this week we have a great group of panelists joining us. We have Dr. Angela Richardson, who is an alumni of University of Miami, who then went on to do a cerebrovascular and skull-based fellowship at the University of Wisconsin, and now has really recently been joining the Department of Neurosurgery in Indiana University as a PI for a brain tumor lab on oncolytic viruses, as well as a brain tumor and skull-based specialist. So we welcome her also. It's a deep passion for today's topic. We are also joined by our fellows, Dr. Higgins from the Department of Neurosurgery here, Dr. Patel, and also Dr. Morel, who's our clinical research coordinator and soon to be our new surgical neuro-oncology fellow. Next. And tonight we have a very thankful welcome to Dr. Bowers, who's joining us all the way from New Mexico. It's a little bit early in the afternoon for him, but we really appreciate him taking the time out from his busy day to talk to us about his topic tonight. He's currently the vice chair for clinical affairs at University of New Mexico, associate professor, and the program director of their newly instated neurosurgical residency program. And I really congratulate him for getting this program up and off the ground. It's literally 3 days old. And so big round of applause for all that he's done in just a short time that he's been there in New Mexico. He's also the medical director of their neuroscience center, director of skull-based and surgical neuro-oncology. He's a graduate of the University of Utah, where he did his residency for neurosurgery, and then he went on to do a fellowship in cerebrovascular and skull-based at Swedish before then, and then afterwards joining Westchester Medical School of Medicine for neurosurgery for about 3 or 4 years before then going down to New Mexico, where he's now acting in this great role that he's done so far. He's won multiple awards for his brain tumor research, has a long laundry list of publications and speeches, but most interestingly is tonight's talk on frailty. And this is something that's kind of passionate to me because here in Miami, we've really looked at our discharges for our brain tumor populations and how to make things efficient and safer for our patients. And one of the earlier works that we did with Dr. Richardson actually looked at discharges, and one of the most powerful screening tools we saw was frailty. And Christian has really just taken this to a whole nother level and has developed this into really a refined algorithm for very subspecialties and subtypes of brain tumors. And we're really excited for him to talk about that today in another level that we haven't looked at before. So Dr. Bowers, thank you again so much.
Thanks, Dr. Ivan, for having me, and thanks to all your team for putting these on. It's been a lot of fun to watch during the pandemic when we were all stuck at home, and we were able to look forward to this each week because there's some times there where there wasn't a lot to look forward to. So we appreciate you that. All right, there you go. So the title of this talk is Frailty and Neurosciences and the Quest to Never Do Harm. I give this talk a variation of this talk frequently, and I always start with this picture. And I ask that, it's hard on Zoom, but I ask the audience when we're in person, I say, what do you see when you look at this picture? And people say, oh, I see old people. Well, the old people or older people, frailty, geriatric patients, all these things come to play every day for brain tumor surgeons. This is a patient that has a right temporal lesion. They've got renal cell carcinoma, and they have pretty significant headaches. And what factors go into determining what to do? What if I told you that the patient was 97 years old, on 10 liters of oxygen, had heart failure, diabetes, and a host of other medical problems, and used a walker to ambulate, and needs some help with ADLs? Well, that'd be a different plan than what you would probably choose if I told you he was 45 and independent and working and had no medical issues other than his renal cell carcinoma, which had been removed and was controlled otherwise. So the reality is that frailty and patient's condition affects us quite a bit, because we don't have a crystal ball in neurosurgery, and there's nothing worse than taking patients to the operating room, thinking you're going to doing everything in your power to get a good result, and then having things go south, whether that's post-operatively as a result of their frailty or their medical conditions. And so the reality is, this guy did great, but went home in a couple of days and everything was perfect. But it's really, we feel like frailty has made a big difference in how we approach patients and how we try to optimize our outcomes, since we have no crystal ball. I'm from the West. I was born in Southern California. I moved to Seattle, and then moved to Salt Lake. So it was kind of 6 years in each place, and then went to the University of Denver to play soccer. But I've kind of always been based in the West, except for my 4 years of medical school at Georgetown, and the 3 years I was in New York. And in my population in Salt Lake, we had a lot of older people that were very healthy. They didn't drink, they didn't smoke. A lot of them were members of the local Mormon Church of Jesus Christ of Latter-day Saints. And so I got interested in this as a resident at the University of Utah, because we had a lot of older patients that were doing better than what the literature told me they were supposed to be doing. This was like an initial kind of poster we'd put together and for a presentation we'd had there. And we were looking at all our subdural outcomes and looking at the literature. And there was a period in the literature where they were kind of cautioning people to not take older patients to the operating room for trauma. And so this kind of we started thinking. I was using Charleston Comorbidity Index initially to look at outcomes. And this was a paper from, during my research year, my residency. So we went and took our retrospective series of just kind of harvested our 250 patients of acoustics. And what we kind of found was that there was no difference in outcomes. For us, we had two amazing, surgeons, the neurotologist, Dr. Shelton, Dr. Coldwell, as the school-based neurosurgeon, but there was no outcome differences for patients based on age. And so, there was other series you could read that showed patients did terrible when they were older with acoustic surgery. And so that was when it started clicking for me that this was really an apples and oranges kind of question, because just because patients were older and had acoustics didn't make them the same. And when I show that picture in the beginning, people think of the patients are just older, but the reality is Hiromu Inada is 89 and he runs Ironman. I can't run an Ironman now. And I played college soccer, Division I. So, I'm not like a bad athlete. It's just, it's not age. People can be old, significantly older, and be robust and not frail. And they can tolerate, major surgical interventions and insults and do well. I think this matters to, all neurosurgeons and all physicians, frankly, because we are getting ready to face a wave of older patients. And it sounds like, I think if you talk to surgeons across the country, everyone's facing this. And we are hitting this peak where we're going to have more and more septuagenarians, octogenarians, nonagenarians, and older patients to take care of. This is another way of looking at it with 2010 in the grayed out and then 2019 in the green. And you can see that as you kind of go up here, the green is overrunning where it used to be kind of contained within the boxes. So this population is getting older and older, and we're going to be seeing more and more of these patients. And we need to have a better tool to kind of help make better decisions. And here in New Mexico, we have a lot of patients that are getting older over this 2010 2019, and not a surprise, Florida, there are some older patients in Florida also. So when we age, people as a general, they tend to have more health problems, whether that's vision, mobility, arthritis, thyroid issues, but that's a known occurrence. This is a recent figure that I like from Lancet that talks about different ways to look at frailty. You can have the physical and biological model where there's 3 or 5 components: weight loss, exhaustion, weakness, slowness, low physical activity. People will test grip strength, get up and walk strength. I spent most of my 5 years as an attending focusing on a deficit accumulation model where we look at a frailty index and we, score patients and then use that to kind of stratify and figure out how they're going to do. There's also a multi-dimensional biopsychosocial model looking at various physical, psychological, and social, parameters. And then there's a frailty phenotype, which can incorporate mood, social, cognitive, oral, and nutritional presentations. So when it comes to frailty and what is frailty, one way to explain it to people is that, if you have a minor insult like a urinary tract infection, and this top part of the box is someone that's robust, you take a little minor irritation from that, you keep, you're still independent, you're doing fine. But patients that are frail, even with minor insults, can be dependent for a period. And when you have, larger injuries, you can, even if someone's frail, they can have a minor illness and they can end up in this dependent area. And as surgeons, we never want to take somebody that's independent and make them dependent permanently. And so frailty helps us predict who's going to, even if they're dependent for a little bit or have to go to rehab, who's going to bounce back and who is not, and who's not going to tolerate that intervention. So the easiest, the safest one is when we have robust patients that we put minor stresses on versus, patients that are frail that we put major, interventions in. And the whole idea here is to not do harm and not have these outcomes. It's logical that the less invasive a procedure is, that, the less that it should matter with frailty. In terms of the major outcomes, it's if you're having a skin procedure, it matters less than if you're having an open thoracotomy. And it's really our trauma and our surgeons who kind of defined this in the literature, as I'll kind of get into. But the amount of intervention really makes a big difference. And it helps us figure out if you have someone that you're doing less invasive of a procedure, less intense, that's robust, it stands to reason that they're going to, not fall into this disabled category, have worse outcomes, and people are having larger interventions. I think that makes sense. Another way of looking at frailty is, trying to identify what factors can be reversed. And there's whole areas of research focusing on different parts of this. If I want to look at strength as a marker of frailty in here and look at how people decline with their muscle mass and so forth. There's lots of studies looking at that. But the reality is that it really comes down to, as we introduced this program here at UNM to, with my partners to all the surgeons of all the different specialties. And some people are like, well, why does it matter that you screen patients for frailty? Because, you do your best, and if it works out, great. Well, it depends a little bit on the show. I call it the showcase showdown principle. But if you watch this show growing up,
Kelsey, $2,500 in cash, a trip to Oregon and a trip to Japan in a showcase. You bid $22,500. Actual retail price, $22,498. You're over by 2.
if you guess wrong and you screen someone and you maybe you don't screen someone, you think they're going to do well, and you take them to the operating room and you guess wrong, that you can have a mortality that's post-operative that is one of the worst things you can experience. And so the idea is, what is the limit, or how important is it that we don't overbid on who we're operating on? And I think it's vitally important that you stay under, and that we're safe with who we operate on. The famous quote, every surgeon carries about him a cemetery in which from time to time he goes to pray, a cemetery of bitterness and regret, of which he seeks the reason for certain of his failures. I've only been in practice 5 years, but I have had a number of patients who I thought would do well with our surgical intervention, or I've tried to do less of a surgery and they haven't done well. And I've had patients die, I've had of other medical issues. And so as brain tumor and skull-based surgeons in particular, but really in all of neurosurgery, we see this quite a bit. I think we really need to have better information to provide patients with and a better idea of what's happening. So as I started this as an attending, moving to New York, and we with my boss who'd been the vice chair during my residency and had become the chair, Dr. Mike Schmidt, I was kind of charged to start building a research program up. And this was one of the early papers after I'd gotten excited about frailty from a lecture about this time of the year in 2017. This was a paper that just measured all the new metastatic melanoma patients that came into the hospital. All they went off of was the thickness of the temporalis muscle. And when they did a median, the patients with the thicker muscles above the median lived a lot longer than the patients with the thinner muscles, Journal of Neuro-Oncology paper in 2018. And when you look at that, that survival curve, that Kaplan-Meier, those patients with the thicker muscles live much longer. And that was kind of what really, after I'd heard that initial lecture, I started thinking how I was going to make this. When I first heard the frailty lecture, I kind of had been looking for this because I've been using Charles Morbidity and other things. And I knew after that lecture in the spring of 17 that I was going to try to have a lot of my career focused on frailty, because it just made sense to me. And I felt like it was going to be a big thing. And when I first saw this paper right after, it really gave me some motivation and impetus, because I said, this is a very cool thing to just be able to know how someone's going to do based on the thickness of their muscle. And it doesn't always work for every patient, but it was kind of what got me, triggered on that. And so when it comes to frailty, there's all these different markers we can look at and how it affects different diseases. And so there's a lot of different ways to go to it. For example, how do you measure frailty? Is it accurate to just look at the patients and put them into a category, of those that are, terminally ill and at the end versus people that are very fit and robust? The Canadian Health, Study on Health and Aging Frailty Index came up with 70 items. And I don't know if all of those in the audience, if anyone knows where the MFI 11 or the MFI 5 came from, but it's pretty interesting because this study, they had 70 items, but if you're going to take 70 items and do an evaluation of someone in the ER, it's going to be a problem.
Well, I was hoping you could run a play for us. We are in a really big hurry.
Sure. What's the plate?
29
Number.
29 THD03.
I can't even finish the video, but residents don't have time in the ER to be doing a 70-item frailty screening. So what was smart about this group is they took this group that took this initial paper in 2011, out of using the NSQIP, the National Surgical Quality Improvement Program database, there happened to be 11 variables that were automatically collected in there, so that you could automatically run these analyses with using an MFI 11 or 11 of the 70 variables, and they made sense. Your functional status, your diabetes, severe COPD, heart failure, and myocardial infarction, all of these things that are fairly important. And they were able to very quickly run a lot of studies through the NSQIP program. And this is especially in general surgery and trauma. Problem was, in 2015, the NSQIP database quit collecting the other 6 variables. That's why you have an MFI 5. I don't know if any people that aren't familiar with frailty, it switches in the literature from an MFI 11 to an MFI 5. And that's not because there's some magical thing about these 5 variables. It's because the database quit collecting the other 6. And so the only real problem with the MFI 5, these are all, for the most part, important things: diabetes, COPD, severe COPD, pneumonia, heart failure, functional status, hypertension, okay, is that it's not really a frailty index as much anymore. It's kind of a nice comorbidity scale. It's pretty blunt. It's 4 factors. Functional status will provide some of that, but most patients don't have that all the time. So it was at this time that once I kind of started figuring this out, that I realized that there was this levels to how I wanted to do this frailty research over the following years. And I wanted to start because in neurosurgery, I want to start by basically reviewing the neurosurgery literature, and I was going to try and define this for most of the big pathologies in neurosurgery that I could. So we started with our team and just looked at all what had been published at that time when we started this at the end of 2017. It didn't get published for a couple of years because we were kind of compiling it. But what we found was interesting in that there's only 25 papers at the time. And for cranial papers, it was even less. It was 3 kind of cranial tumors, 1 mixed cranial and 1 hemorrhage paper. And the rest was spine, deformity, degenerative, and spine tumor. So that's where we kind of started in 2017. The other problem was I was just learning about frailty, and I didn't really know in the literature. It wasn't very helpful for neurosurgery in particular because people were defining frailty different. If you had 1 variable, were you frail? If you had 2, some called that pre-frail. Sometimes didn't define severe frail until 0.3. Some just said you were either not frail if you had nothing. If you had 1 or more, you were frail. So the literature was very mixed that way. But we started looking at it, and one thing you could always count on is even in our healthy population in Utah, we found that it was actually increasing frailty and not increasing age, which resulted in longer length of stays for our vestibular schwannoma patients. And that seems pretty simple now. I think everyone kind of knows that frailty matters more than age, but that wasn't really known. Like for any of these brain tumor pathologies, when we started looking at this, there'd only been these handful of papers that were kind of mixed, and it wasn't really clear. And so that in and of itself was kind of a newer concept when we started looking at this. And so we basically, I was building a research team, and I do a lot of medical student mentorship, and I was working with a lot of medical students and getting them to, help look through different databases and start doing a lot of chart reviews and starting to look at these factors. I was wondering if in New York, where the private practice surgeons make a lot of money for procedures, was there an issue with, was it an insurance status issue based on transfers? Who was getting transferred in? And we found that patients that were frail and had more surgically complex conditions tended to be a lot more likely to be transferred, which was interesting. So, you know, it wasn't the insurance status or even the age like we thought it had been originally. So surgeons are kind of already identifying this by picking frail patients more than older patients to send. And then this was before frailty, because the paper I'd published during that research year of just when we found out it was age, and it kind of, this was before frailty, and you know, we basically said it didn't matter for age because we didn't really know what to look for with frailty. So we then found something interesting with angionative subarachnoid hemorrhages. With one of our students took this group and looked at them and found that frailty mattered more than Hunt-Hess, Fisher, in really determining outcomes. And that was kind of shocking to us that it was that important in this case, frailty was. And so when you looked at these ROC curves, yeah, Hunt-Hess and Fisher were important, and even age was important, but you know, mortality and discharge status was better determined by frailty than any of them. And so this is kind of where we first started kind of really getting excited about what we were finding. We were probably about a year to year and a half, you know, the first 2 years of being there, of getting into this and figuring out that, you know, the frail angionative subarachnoid hemorrhage patients had worse outcomes and increased mortality than the non-frail. And so we started, you know, recommending using it for that group. And then we started looking at a whole bunch of things, aneurysmal subarachnoid hemorrhages, where frailty did not matter as much in this group. And we started, although it was associated with worse grades, it was still, you know, the standard scoring system was better for Hunt-Hess and so forth. Then we started looking at ICHs. ICH score was still better. We started looking at a different study. We used a different method and used an MFI-11 by coding it for ourselves in the NIS database. So not using an SQIP anymore, going to the NIS and spending a long time developing the codes for the MFI-11, seeing if those extra variables would do a better job than the MFI-5 did. But in that paper in particular, although it helped, it was still you know, age in these aneurysmal subarachnoid hemorrhage patients, or in the ICHs as well. Found the same thing. We looked at MFI-11, M5 together. They were still more predictive than any other factor for angionative subarachnoid hemorrhages. We looked at acute subdurals, looked at chronic subdurals, trying to find different factors. No one had defined frailty for spinal epidural abscess patients. We just took a couple groups and compared them to each other, regular control groups of back pain patients in the ER, and found that you know, obviously spinal epidural abscess patients were more frail and that they did worse. The frail ones did worse with treatments. You know, there's some certain diseases that are really great for frailty. Odontoid fractures for our spine partner colleagues have a lot of older patients with odontoid fractures, and this paper is not published quite yet, but we won a kind of an award at the big Congress surgery meeting where we presented at the trauma meeting and showed that the frailty mattered more than age for the older odontoid fracture patients. And then in October of 2020, the Neurosurgery Focus came out with its first geriatric kind of neurosurgery focus, and we had our first kind of MFI project. I was pretty new at this and hadn't really developed the kind of how I wanted to do it yet, but we just looked at frailty in this small cohort retrospectively and found that it was, you know, associated with worse outcomes following meningioma resection. So increased length of stay, readmission rate, worse discharge disposition. And so that was the first time we were able to kind of show in meningioma patients that it mattered. But, you know, it's amazing, like pretty much every time I'm in clinic or on call and get consulted, we're always dealing with patients with meningiomas that are older. And so it's become quite relevant. And, you know, I quote a lot of the papers that we read on meningiomas quite frequently with patients. And even if it was just for length of stay, in this case, looking at frail versus non-frail, it was a significant difference. And I think that's even helpful in of itself as we looked at, you know, length of stay, discharge, and readmission rates. We then looked at you know, meningiomas with baseline frailty in a larger database this time, so 20,000 patients instead of doing a retrospective one in our own system, and I found that frailty did a better job than age at predicting outcomes. Clavia and Dindo for complications such as ICU admissions, takebacks to the OR, deaths, and extended length of stay. So that was a big turning point too, because we kind of validated what we'd first discovered in our own little retrospective chart review at a large scale 20,000 patient series. And then we moved to the NSQIP and did 6,000 patients from 2015 to 2019, looking at MFI5, and it was still a better independent predictor than age. For the major complications, in particular with the severe frailty, the odds ratios are quite high, and it did a good job predicting mortality, which is always really important with any surgery, especially with these meningioma patients, major complications, unplanned readmissions, and so forth. So this is also looking at displaying those odds ratios and effect sizes, looking at how frailty, kind of compared to age in that paper, and showing how bad, in particular, the severe frail were in terms of their outcomes for all of these major outcomes: mortality, major complications, unplanned readmission, unplanned reoperation, extended length of stay, non-home discharge. So, it's easy in the slides, but this happened over started this almost 5 years ago. I'll be 5 years out in a couple months. So this happened over these years. We started doing these studies and looking, and then we started looking at other diseases, with pituitaries. We found for the first time that it had been shown that it was increasing frailty and not advanced patient age that was an independent predictor for major complications of pituitary surgery, unplanned readmission, extended length of stay, non-home discharge. So frailty was superior to age and preoperative risk stratification for pituitary patients. Doesn't seem like a big deal, now, but that was something that we didn't know when we started this, and we were excited about trying to figure out. And if you look at just like that paper and look at these graphs, it's interesting how when you look at like major complications, how it doesn't peak as much as you would think versus when we look at frailty, how it really jumps up. I'm seeing an 86-year-old, she's almost 87, in the clinic, and she's got a pretty big pituitary macroadenoma. Her vision is terrible on the left. It's it's not great on the right, but it's kind of stable, and the thickness of her nerve is okay, and she really wants surgery. And I'm really trying to kind of say, well, let's see if we can hold off on surgery, because you're 87, and she is kind of in between. She's frail, but she's not severely frail. But it's really helping us kind of have these discussions and coach these discussions. And I'm presenting her at our frailty conference tomorrow, which we do with the geriatricians and the anesthesiologists and the general surgeons, and have a discussion with them if we can do anything to mitigate risk and how we can help. But it makes a difference in framing the discussion, I think, and it's been helpful for us to see these, to know that cutoff, and know that if someone's severely frail, these are the odds ratios they can, versus pre-frail patients. And I think that's been helpful. So when you look at the ROC curve for the MFI5 versus age, it's not earth-shattering, but it's helpful, and it's discriminatory, and it's better than age is for sure, in terms of like estimating what's going to happen or knowing what the chances are for major complication. We might end up operating on this 87-year-old, but last time we talked, I said, your risk for a major complication is increased compared to healthy patients, and she wanted to think about that. And I think it was her, and her daughter comes with her, as a lot of these older patients do, and just even taking a pause and having that discussion is helpful. And we're going to see her back in 6 weeks and kind of revisit it with them. But we don't have a crystal ball, but we can do some things better than I think we've done in the past to give us an idea of what's going on and what we can expect. So we then kind of, tried to look at the real big skull-based pathologies first: meningiomas, acoustics, pituitaries. This is our paper it was published in JAMA Otolaryngology, looking at baseline frailty status and age, how those associations with outcomes in patients undergoing vestibular schwannoma resection, with one of our amazing med students, Alice at New York Medical College. And we looked at a large series from the NIS, and looking at that same question, 27,000 patients, and finding that frailty was more accurate for predicting outcomes and guiding treatment than advanced patient age alone for vestibular schwannoma resection. And for the major outcomes, mortality is the one that tends to be, for a lot of these studies, is the one that, besides being most important, tends to follow frailty quite a bit. Also for routine discharge, hospital length of stay. And we found that to be pretty strong, and about as good of a ROC curve as you could hope for, looking at MFI versus age for a major tumor. So we were pretty excited to get that published, and for what we found. This is looking at postoperative cerebrovascular infarction or hemorrhage, and this is looking at in-hospital mortality. So it's amazing, the difference between frailty and age, because a lot of the literature, if you go back and look at it from that earlier paper when I was in residency and didn't know about frailty, I'd known that literature pretty well, and it really focused on how age was the the end all be all, old age of who you could operate on and who you couldn't, and that's just not true. We then started looked at metastatic brain tumor resection patients, and found similar results for frailty, predicting better than old age as well, which is important. Do we want to end at 45? Is that right, Michael? Is that about Dr. Ivan? 3:45? Is that when you just want me to finish up? And do 3:50? Maybe frozen. Just make sure to go along. So looking at spine tumors as well, since this is a cranial skull base, but I think tumors have a role. We just recently published this NSQIP study of 4,662 patients, showing that frailty as measured by MFI-5 is a more robust predictor of compared to age for all, looking at all the major variables. And frailty matters a lot more than age seems to for a lot of these things. And when you look at them and compare them together. So, and that's another, great receiver operating curve. And the area under the curve for MFI-5 is significantly better than age for looking at these. So it's helping us dial in that crystal ball a little bit and, at least predict better. We published this letter about the need to look at traumatic spinal cord injury with frailty. And then we've got this paper accepted with revisions for traumatic spinal cord injury, looking at frailty and doing a decision tree analysis. Not going to spend a lot of time on these since the purpose of today's paper or talk is on skull base and brain tumors. But also, we started collaborating with other colleagues. I have a good friend who's a neurotologist that when I was a resident, he was the attending, and we had some other social connections outside of work and knew each other quite a while for a while, and started helping him with do his cochlear implant studies, and we helped set this up, and they presenting that at their major meeting, and finding similar results. In this case, it was to help them because old age seemed to be important, and they could actually do these cochlear implantations, which was super helpful for them. And we have done some other projects, and these are a couple book chapters we'll skipped over, but just talking about what things you can do preoperatively, whether that's getting geriatrics involved, looking at nutritional status, and how you can, is there a way to optimize patients? So just to kind of put some of this into context, we've been hired to kind of rebuild the research department at the New York Medical College and Westchester Medical Center residency. And so we developed this research program, which really based along this frailty research, where, this was kind of the red lines, kind of where we started this research intervention and doing these frailty studies. And we were able to make a pretty significant difference off the bat by doing this monthly research meeting, setting goals, and really using frailty studies as the bulk of the research we were doing. The blue is for residents, the red is for medical students. And you can see medical student interventions were really kind of a big part of that. And posters were in green as well. So, when we moved out here to New Mexico, we were hired to rebuild the residency program. And one of the things that, I kind of talked to them about is how we were going to try and start a similar type program here and expand it. And so this is kind of how you have to have some sort of way to organize all this data. There's so many students and there's so many projects going on. And we had an amazing pre-residency fellow, Dr. Kazim, who we actually, we'd interviewed we found out Friday about the residency. We had all our interviews Monday, and Dr. Kazim was just, is going to be our first resident. So big congratulations to him. He's been instrumental, worked tirelessly throughout this process. And this is kind of how it's called a smart sheet. I don't know if a lot of you guys use it, but we have all of our medical students from different places organized on here, and all their projects are organized on here for frailty. And so this is how we kind of keep track of things. And, I get a lot of questions from, people, how do you get into neurosurgery, or get contacted by a lot of former medical graduates, how do you match into neurosurgery, or how do you get a neurosurgery spot? And, one way is to really make yourself invaluable to a program and be extremely productive with research. And when we look at the interventions we did here at UNM over 18 months versus what it was before, and kind of mirroring that what we've done at Westchester, we're going to wait till the next year to publish our results here, but it's really been built on this being able to do a lot of high quality frailty research that's made a huge difference. And so we've worked with a ton of students from all over. We've published a lot of papers using this methods, and we have 23 right now, I think, that are under review, and 50 more that are kind of in the process, and have been able to, get a lot of medical students. They're the majority, they're first authors on the vast majority of these projects. So we've been able to use this as really a way to mentor medical students and build a program for research very quickly, and get a lot of results and get a lot of publications for the medical students. And people ask, like, well, what does it take? And, I just grabbed this because Dr. Kazim Syed he was having meetings the other night, and I just happened to see his calendar, and this was his Saturday evening. And a lot of people want to be a neurosurgery resident. We had 27 applications for this residency spot, since the news went out Friday night, we got the residency back, one business day, we had 27 by the end of Monday, but very few people want to spend their free time when they're not in the hospital meeting for hours on end with students, teaching them how to do statistics and run these analyses. So it's an aside, but it just goes to show that it makes a difference when you can kind of do these sort of interventions, and really makes a huge difference with patient outcomes and also with building a program and a culture of research in a very short period of time. You can do it. So we knew kind of in the last couple of years, we were going to be moving on from MFI5 and MFI11. We've written a lot of papers about that. But it wasn't until I got into New Mexico that I'd met Dr. Rohini McKee, our chief quality officer, and her and I, right when I signed the contract in January of 20, she called me, we got online, and we both had a shared interest in frailty. It's big in general and trauma surgery. And she introduced me to Dan Hall and their group, and really the risk analysis index. So this is for the remaining part of the talk. This just shows kind of the publications over the years. And we started this back in kind of towards the end of 2017, and how it's really taken off. This is coming up on a meta-analysis we're getting ready to publish, showing, the bulk of these are in spine, but there's certainly a fair amount of other categories covered, including tumors and intracranial tumors in yellow. And these are the different types of studies that it's made of. And these are all the different frailty scales that are out there that have been published in the neurosurgery literature in these 180 scales and 137 papers from up to 2022. And the vast majority, not a surprise, MFI5 and MFI11. And why is that? Because it's really easy to run these, relatively easy compared to gathering charts on thousands of patients or doing things. It takes time to learn the coding, but it's relatively easy to run them compared to some of the other scales. And it's, tends to be what's more common in the literature. So although that's half of what the neurosurgery literature is, and when we looked at kind of our experience, this is just publications up to 2021, doesn't count the handful we have in 2022. And this kind of breaks down the different scales, use the most commons for these. And the different pathology types are shown in kind of a different way. But it was right after I'd started here that I knew we were going to be shifting over the next couple of years and starting this risk analysis index, which we learned from this other group. So this is Dr. McKee. She's amazing, been an amazing partner, and she's helped us kind of launch this on a whole hospital scale wide. Dr. Kazim wrote the IRB and all the protocols to make this risk analysis index could be done for any of the surgeons and any of the clinicians. And this is some of Dr. Hall's work. I'm going to kind of skip through it a little bit, but the reality is it's a different scoring system, but they follow these patients out for a long period of time. And the reality is the patients that are robust, not frail, with the risk analysis index live a lot longer than the patients that are frail. And that's relatively straightforward. But they did this in a bunch of papers and looked at a bunch of different populations surgically from when they had their first surgical procedure. And the reality was that these robust patients live long, and the frail patients, they do not survive as nearly as high of a rate. They do worse. And they used this to implement some big changes in the VA system. And they found that by doing a surgical pause and making surgeons think about the risk, the frailty and the risk assessment, they found that it made a huge difference in mortality. And Dr. Hall has been a huge mentor and really owe him a lot. He's out of Pittsburgh and their group. And this led to some huge reductions in mortality. And when it came to patients that had, if they were healthy or low robust here in the green, and they had major complications, they could survive and do okay with it. But patients that had high frailty scores and had a number of complications survived at much higher 30-day mortality rates. And so, this is where we've been spending the bulk of our time as we've been transitioning over. And we set up a prospective RAIC. We have 18 plus months worth of data for every neurosurgery patient that comes to the clinic or that comes to the emergency room gets a risk analysis index frailty score. And it takes about 40 seconds for our team to do them. And I'll go through that at the end if there's time. But this is a RAI, risk analysis index study, looking at pituitaries, getting back to brain tumors and the purpose of this talk. And it was extremely helpful for mortality, area under the curve of 0.894, compared to the MFI5, which we know does a lot better job than age at predicting outcomes. So that's a huge difference. And we see that for almost everything we run risk analysis index for, that it does a much better job, statistically significant, at predicting outcomes more than the MFI5 does. And this is a paper we submitted to Annals of Surgery, looking at all brain tumor patients, meningiomas, METs, and looking at gliomas. and malignant brain tumors, malignant gliomas, and looking at all the major outcomes. And you can see just from a far distance away, 10,000-foot view, that these high frailty are using the RAI, these odds ratios, they're powerful and they give you a lot of predictability for all these major outcomes. This is just showing the multivariate analysis, and there's a lot of numbers in there. So just take a step back and look at the major outcomes and using the MFI-5, pre-frail, frail, severely frail versus the RAI-A in these different categories. And so it's been helpful for us, and this shows it in a little bit of a different way, these different curves. And so it's hard when you're looking at 30,000 brain tumor patients and you're trying to look at all these different outcomes. What we've kind of had discovered as we did this transition is we needed a more efficient way to show what we're trying to say, which is frail patients do worse than non-frail patients, and it's not age, and that RAI is good. And so we've kind of, as we've worked through this, I'm just going to show this quick little spine example that we've recently submitted on 300,000 spine patients. I will call attention to one point, which is just if you look at the percentages over here versus non-frail, pre-frail, frail, with the RAI, there tends to be a little bit less that are classified as frail, but it tends to be do a better job of really predicting the outcomes. So when we look at this is kind of how we want these big, huge numbers of patients. We want the outcomes to end up being this, because you don't get drowned out in all the data. So this is 300,000 spine patients all combined together looking at mortality, complications, reoperations, and non-home discharge. And this RAI does a much better job, especially for mortality, at predicting outcomes than the MFI-5 does. And remember, if we were going to draw the MFI-5 and age up here, MFI-5 would be doing a lot better job than age would. So these are really powerful scales shown over huge numbers of patients, predicting really important outcomes. And we're really even starting to move away from these rock curves and just show the C statistic for all these, which is really showing you the area under the curve and the significance of it. RAI Rev versus MFI for mortality, it's a lot better. Same with claving endo complications, same with reoperations, same with non-home discharges. And that's for, a huge number of patients, 300,000, and using these coding. And so that's, I didn't want to ask, I'm honored to be here and share some of this. I didn't want to ask to go in 6 months, but in 6 months, I'll have all these RAI outcomes just like that for, the major brain tumor and skull-based pathologies submitted and published, hopefully. So we're just finishing up most of those projects. But I just, for the last few minutes, want to just run through this with the group, because it's not complicated, but this is what we do for every patient that comes in. And it's all electronic on the computer. But you basically find out, you run through this list of them. They have kidney problems, CHF, shortness of breath. And our APPs do this for everybody. Our residents, or our pre-residency fellows do it. And you get a lot of points for ADLs. So if people have impairment, that's where you pick up a lot. And just on the surface, the reason the risk analysis index does a lot better job than the MFI is because the MFI doesn't give you any points for your age, whereas the risk analysis index builds this into the calculations. We use Cerner. I like Epic a lot better, but we use Cerner. So we have this saved as a dot phrase for every consult. It goes right at the bottom of them. Every admit, every consult, every clinic patient gets an RAIC, prospective RAIC score recorded. And then we share this with the whole hospital. So any surgeons or medical doctors want to use it can just grab it and use it. But the reason I think it scores so much better than the MFI is because for most things is because you get points for your old age factored into it, whereas MFI-5 doesn't do that. And then it scores all of these, these major things. If you have cognitive impairment, you go down this side for your scoring. And if your ADLs, depending on how impaired you are, you get anywhere from 0 if you're normal, or 16 if you're completely dependent. And that gets added to these, and you get this overall sum. And so, this kind of just goes through it kind of step by step. But, it's some of the general surgery and trauma literature, the pre-frail, the kind of frail would be like 23, and then 37 is where, for a lot of those papers, people really with severe frailty really have a high incidence of bad outcomes. And so this is something we've been collecting for a year and a half with our red cap, and we're looking forward to publish. And that's really kind of, I wanted to save some time for any questions or discussions, but that's kind of the bulk of what we've been doing. And we're just really grateful for the opportunity to share this with you. And we're grateful for what we really feel like we're just now starting to kind of get the frailty research dialed in, and really feel that this RAI is going to be what's used for a long, long time, and find it to be the most accurate. And we're excited to kind of be doing all these papers. We have got a book just approved that we're going to be publishing next year, and then also I'm going to plan for an NIH grant with this as well. So, and hopefully looking to establish a frailty network. So, thanks for everyone's time and for listening, and happy to answer questions or discuss any of this.
Great, thank you so much. That was very, very enlightening and very interesting. And I don't want to get to too many of my questions yet, because I'm pretty sure our panelists have some, but I just wanted to ask you real quickly, what is your, obviously getting the data and collecting the data is good, but how do you then, what's your discussion with the patients when they have frailty and high frailty or high RAI? You kind of alluded to it a little bit in the talk, but I just, for the residents and the medical students that are listening, how does that discussion go?
Well, I think in general, let's say it's someone that's really severely frail, and we have let's say they have a large, brain tumor, for example. It helps us kind of sit down with them and their family and say, look, you are at high risk for having a bad outcome. Well, what does a bad outcome mean? Well, it can mean a number of things. It can mean, complications with infection, reintubation, stroke in certain situations. And we talk about the fact that we are still kind of doing a lot of research on this, and we feel like we say to patients commonly, we feel like we are the most published group, and this is something we actively look at every day, and so we feel like we have a good sense of it, but we still don't have exact percentages to give them, but that we know that they are at a much higher risk of bad outcomes than their peers are that are healthy, and that they need to think about whether the risk makes sense of doing that treatment. And so you can imagine the next step is, and I should go back to the kind of pyramid here, because we're really still at the very, very, very bottom of this pyramid. We're talking about, all we've done so far is written these MFI5 and MFI11 papers, basically. And we're just now getting excited because the risk analysis index is much better, and it's a much more powerful tool. And we just are getting ready to analyze all our prospective 1.5 year RAIC data. But we feel like we are starting to get to this point where we can do a much better job, but we still have a long ways to go up this pyramid of being able to, more accurately predict. So I don't try to pretend like we know it all. We just, I think, get the point across that they are at a higher risk than their peers that would have that are healthy, and that what that would look like in terms of complications. And it just helps us kind of frame the discussion. And I think that's usually been enough to at least have some discussions about it,
Great. Angela, you want to ask anything?
Yeah, I had a question. I think I saw it on one of the graphs. You looked at frailty and race and ethnicity. Have you looked at anything at frailty and like socioeconomic status or other social determinants?
Yeah, great question. The journal editors went crazy about the finding, and we actually didn't want to focus on it too much because there's a lot of strong opinions. We have the highest percentage. This is going to shock the people from Miami, but we have the highest percentage of Latin American population. We're 47.8%. It's really high. And so, diversity is huge to us. Looking at racial disparities is kind of what we're all about at University of New Mexico. And so we are doing a whole separate series of papers, which I haven't gotten into yet, and we haven't published anything on it yet, but is looking at how frailty affects that, because it's those that are in these racial disparity groups that are frail are going to do even worse than those that aren't. And so we haven't even tackled it yet. And in that paper in particular, we didn't, it's back on the vestibular schwannoma, but we really said as little as we could and still get it published, because it was something that warranted its own discussion and focus. And it really, everyone was cool with the frailty stuff, but the fact we found this, we didn't want to bury it, but we also, didn't feel like it's not an area that I can talk about all day like I can with frailty, but it's an area that we're focusing on. And I have a medical student I'm mentoring right now who, grew up here in New Mexico, is Hispanic, and is going into neurosurgery. And, she's really making, right now, we're kind of defining all these for her, and it's going to make that kind of a focus for her career. And it's exciting.
Awesome. Well, I'll look forward to seeing that. Thank you.
Yeah, great question. Thanks.
Okay. Who else from the panelists? Any questions?
Hey, if you don't mind, Dr. Ivan, I just had a very quick question. I was pretty shocked to see that Hunt Hess comparison.
Yeah.
I was blown away by that as well. Just very quickly, I'm just trying to think about this from the context of patients in the office, and we've been pretty lucky here at UM with collecting a lot of our data on enhanced recovery, and being very good about discharging patients early and getting them back on their feet and back to reality. Sometimes I find patients who are with family members, like an elderly, a patient comes in and they have their son or daughter or their grandson or somebody with them. And, we explain to them, like, look, here's what we expect. This is a small lesion. We can expect you to go home the following day, et cetera. And like, they're kind of taken aback by that, much like, I guess, physicians are ingrained in thinking that older patients, are not going to do well, are going to have longer hospital stays. I feel like the population as well is also kind of ingrained with that. How do you utilize these scales and, various indices in the office? And how do you sort of convince patients that, look, they're fine, even though they're older, it shouldn't make a difference?
Well, I think, I print out these papers. A lot of times we talk about it, depending on it. But, there's a lady I'm going to share a story of that I did recently. She found a lesion, left occipital, smallish lesion. It looked like a met or a glioblastoma. It looked like it was cancer. And I recommended she have it come out. She's not frail, but she's in her 80s. And she did not want to have it out. And I said, okay, I think you're pretty healthy and you'll tolerate this well, but you are in your 80s, and that, so it still matters. Long story short, I said, it had already been a month, like 3 weeks before she got into me. And then I said, let's just reimage this in a couple of weeks. And if it's grown, I think we need to take it out. It had grown. We took it out. She was like, she was a healthy, robust 83-year-old. She got out of the hospital, for us on like day 2, we're a huge state where we're the only neuro ICU level 1 trauma center. So we don't like to send people, 5 hours away very quickly, but she went home really quickly, like a young person. And she came back 4 days later in status from a non-surgical site location in the temporal lobe, and had to be intubated eventually for her seizures that were progressive. And, the point is, I think we did everything right there. Like, I think even more than a lot of places would. We were using frailty screening. We were, but it's such a bad feeling to take someone like that. And she probably could have recovered. She was intubated for, getting the seizures under control, but she was going to need a rehab stay. And, we had a gross total and she was intact, but the family just felt like that wasn't really what she'd wanted to do for the last year of her life, was be in rehab. And so they withdrew on her and she passed. And it is such a bad feeling. And even this being like the area that basically the only thing I know anything about, or trying to learn about it and know about it, it's just such a bad feeling. So I don't talk a lot of people into surgery. I try to just caution them and tell them when I think that they're going to do better than the average for their age, but just try to make them aware of the complications. We just, I should have posted, I meant to put the slide on there, but we just did a 93-year-old awake. She's very active. She goes to the gym every day. This is not something we normally do. She's the exact robust person. She had a small lesion in her motor strip. We had to do her awake, or I felt like it was safest to do her awake. And she, has done really well. She's been slower than a 30-year-old would be, understandably, but she's done well. And I think there is a rare circumstance. So a lot of the surgeons push back sometimes on introducing frailty because they feel restricted by it, but it also allows you to find patients that you normally maybe wouldn't do surgery on that are healthy and robust, that'll do better than just looking at their age would suggest. And they did a big story on her here in the news, and I meant to put the slide in there. She's awesome. Her daughter texts me every day pictures of her and like how she's doing. But I think that is the flip side of it too, is it allows us, I think this is kind of what you were saying, Nitesh, is that there are patients, you guys have this great ERAS there. You guys are going to be way ahead of the curve. Like most places don't have that. So when you find your robust patients, even when they're older, you guys publish your series of robust ERAS, enhanced pathway patients are going to do better than anyone in the world. And so that's where I think it becomes exciting, because then you can start defining that for this group. And will be a nice standard for everyone to kind of look at, because that's hard for a lot of places to do, is to get that pathway built and get the team built. And really where I see this going down the road for the rest of my career is, who can we prehabilitate? What can we prehabilitate? And this is really for our spine surgery colleagues too, because a lot of their 80-year-old, spinal degenerative disease is not emergent or urgent like we deal with skull-based tumors or cancer. And so, but my dad has a terrible back. He played college football and played football for years. And there's not a great surgery for him that's not massive, that I don't think he would do well with. And so he gets by with chronic pain interventions. But these are the kind of things where, let's say there was a surgery, does prehabilitation help? How much? And I think it's less for those with cancer. We can't prehabilitate brain met patients, but I think you could see what's a good study to do for these patients. Well, you have a metastasis that could go either way. There's equipoise for radiation, SRS, or removing it. Well, maybe the person with an RAI score of 45 gets SRS, and the person with an RAI score of 12 gets surgery. And that's one that would be, that I think it would make sense to do because those situations come. And so we incorporate it into our tumor board and have these discussions. But I think you guys have a particular opportunity to show how well you can do with this, this focused pathway on these patients that are really robust.
Thank you. Awesome.
I think Alexa will be starting to work on that tomorrow.
Sure.
Alexis,
Sure.
any thoughts?
Yes. Yeah. I mean, great job, Dr. Robertson. Awesome job. I have a question actually. What can we do to optimize patient care in terms of frailty? Do we have any experience with any interventions in the brain tumor population to make this to make them less frailty, mostly in the preoperative period?
That's a great question. And really, I think one of the things I wanted to do with all this wealth of information is show that anybody listening to this talk, there is a million places you can jump in and get involved. Now, there is some rehabilitation stuff, like I said, on the spine side. I barely didn't wanted to show spine slides at all tonight, but I just, other than to show how we've kind of refined this and how we're going to start doing these studies going forward. So it's taken me 5 years to, figure out how to do it. And the other thing is, a lot of people can do this. I was not a great scientist. Like I got into residency with no publications. I had a medical school interview for a residency interview for neurosurgery, and the attending picks up the phone and is yelling at the secretary, like, you don't have his research. And I was like, there's no research there, and this is something that I had a passion for and I got interested in, and I knew I could be successful at it. I was an athlete. I didn't spend a lot of time in the lab, but you don't have to be, this genius in science. You get yourself surrounded by good people. All of these major breakthroughs I had on these studies were at the result of my awesome medical students that I worked with, Matt McIntyre, Alice, Syed Kazim, these Princely Fellows who, were really able to, I know how I wanted to do it, but they were just great at the science. So you can pick something here and look at the question first is which patients can wait for a little bit for surgery. I had a pituitary patient that was on oxygen at baseline. And this REI score is not perfect, but I think it's a great one to use because, he was on oxygen at baseline and outside of the surgery part, like he had pulmonary issues afterwards. And, so I'm like, oh, is that something we should look at, separate? How many points should you get for that? And so is that something you could even prehab? If it's some baseline condition you can't improve, that's not a place to look at. So I think it makes a lot of sense in degenerative spine. I think for brain tumors, maybe it's mere meningiomas that can wait, and you're trying to figure out what to do. But I think you can be the one that writes that, writes the part on that and looks at that, because basically in neurosurgery, almost anything you want to look at, most of it has not been done yet. All these, especially all these side things, temporalis muscle thickness, wide open. We're tracking it but we haven't had a chance to get to it because we've been trying to solve this main question and every single pathology is wide open for, and they're all important. I didn't know I was going to be doing a bunch of spine research, but I enjoyed like these outcome predictions, and it's important for these old patients.
Thank you.
I have the opposite question. Is there anything data that says trends that the frailty index actually worsens as a patient ages? That's the old question that we have a lot in skull base. We have these slow growing tumors. The patient comes in their 40s or 50s. We talk about radiation versus surgery, and we talk about, okay, well, if you intervene now, when you have a good frailty index and you're healthy, you're likely to do better, but there's always a risk of surgery. We could wait, radiate, or you could wait several years, but your your age is going to go up, your frailty index may go down. If they're already kind of trending at a level in their frailty, is there anything that shows us that it's likely in the next 5-10 years it's only going to get worse or not?
Well, basically, when I started, I think June 1st is 5 years for me. So when I started, there was those 25 papers. So for cranial stuff, since that's what we're talking about tonight, there was basically 3 on like some sort of mixed tumor. So all of what I basically showed, there hasn't been anything that's followed that because we haven't really followed frailty research for that long, and we've still been kind of trying to figure it out. If you look at this scoring system, which of those things are going to change over time? Well, if someone loses independence, they're going to get points for that. You get points for being a male. But unless they're developing any of these conditions, CHF, which can happen over a decade or so, kidney failure, do they develop dyspnea? Have they been diagnosed? If they develop some other cancer, that's going to make a huge difference. They start losing weight, they lose their appetite. Unless they get ADL impairment, which is kind of hard to get, you got to significantly age to the point where you can't take care of yourself. Or if you have this cognitive disturbance set in, when you start having cognitive issues set in, then that's what makes a big difference too. And it's hard with brain tumors, right? Because that's gonna happen for them anyway. So I don't think it's been defined just because we haven't followed it long enough. But I think you have to look at which one of these factors would be more likely to come over time. And I think this is a good starting point. It's not frustrating to me per se, but I know it's frustrating to those that have spent like a lot of time and a lot longer than I have, like Dan Hall and these people, these experts from the geriatric network within the surgical quality improvement program and general surgery, is that you look at these number of scales that are coming out. And there was a JAMA surgery paper published recently, like within the last 40 days, that has this it's a good scale in a sense of like it does a good job predicting, but it's a scale that like Kaiser's computers uses that like nobody else uses. So it's like if it's a big huge thing, if it's not something you can use very quickly at the bedside, then how helpful is it? And I think that's we can come up with own scales forever, but at some point it'd be nice just to pick something and use it. I think this risk analysis index that I look across all the literature is going to be a pretty solid one. It doesn't mean it's the best one ever for anything, but it's one that could become kind of a language, because at some point we have to, focus on some and try to like have the same language. Otherwise we could do this forever, which my medical students would love. I'd like to kind of climb up the pyramid a little bit eventually. Right,
definitely.
So that'd be another good study. It looks like you could get Alexis on that one too. You can start tracking him. He's gonna be busy. He'll be good.
He's already busy.
I'm sure.
Okay, great. Any other questions for the panelists? Okay, awesome. All right. Well, Dr. Bowers, thank you so much again. This is really interesting and thought-provoking. Also gave a great insight into some great research projects for people who are interested. I've already had a bunch of people ask me for your contact, and so we will try to get everybody connected.
Happy to help. I gave this talk to Pacific Neuroscience Institute because I'm good friends with Wally, was a co-resident of mine, and Neil Martin loved it. And I said it's on my with this NIH grant I'm applying for. I'd like to start a prospective network, and would love to have Miami, Carolina Neuroscience Institute. I'm supposed to go give a lecture over there in Pacific, and would love to do this as a group, and everyone kind of pick a different project they want to take and take the lead on and publish. It'd be great.
That'd be great. That'd be great. Yeah, happy to help. Okay, everybody. Well, stay safe. Thanks again so much, and we'll see everybody here back next month for the next version of our symposium. Thanks so much.
Appreciate you guys. Take care.
Okay.